My name is James Kane. I'm an associate professor of anesthesiology at the University of Pittsburgh School of Medicine. Today I'm going to talk with you about neuromuscular diseases and disorders. The organization of this lecture has been based upon the American Board of Anesthesiologists keywords, and if you look at the topics and titles and numbers, you'll be able to readily find them in that catalog. I have nothing to disclose financially, and we'll move right into my lecture. So this talk will be again about neuromuscular diseases and disorders, and they can broadly be broken down into demyelinating diseases, primary muscle diseases, channelopathies, and myasthenic syndromes. And you'll notice, just take a quick look at this photo on the right-hand side of the screen, and you will see a sufferer of one of our neuromuscular diseases and disorders. Keep this in mind for later on in our talk. The demyelinating diseases can be broken down further into multiple sclerosis, motor neuron diseases, Guillain-Barré syndrome, and Charcot-Marie Tooth, among others. But these are the ones we'll focus on today, as again, per the American Board of Anesthesiologists keywords. Multiple sclerosis is a degenerative disease that attacks the nervous system. It's believed that it works by white blood cells attacking the neurons. You'll note the neuron and a healthy myelin sheath coming down here with its intermittent nodes of Ranvier, which again markedly speeds transmission of the nerve signal. As you'll go down here, you'll notice these myelin sheath and possibly the nerve itself are damaged. And this appears to be the way that multiple sclerosis affects the nervous system. With this disease occurring, nerve signals themselves are slowed or blocked, and that's where the symptoms of multiple sclerosis come from. Symptoms can hit pretty much any part of the body. Centrally, you'll see people who have fatigue. Depression is a central component of multiple sclerosis and seen nearly universally to some degree. Some of the early signs and symptoms that you'll notice with folks who have multiple sclerosis, in fact, oftentimes it's the presenting problem, is a diplopia or nystagmus that somebody occurs, and they all of a sudden start to have visual difficulties that they never had before. Another component you'll see is a hoarseness of voice or a dysarthria, again because of the muscles of the throat and speech are affected. Further along, you may end up having problems with other parts of the musculoskeletal system, such as weakness, spasm, ataxia. The sensory systems also involved. Pain is a large component of multiple sclerosis patients. Incontinence, diarrhea, constipation occur from both a bowel and a urinary standpoint, with urinary retention being also a very, very common complaint of these folks. How does this concern us in anesthesia? Well, let's take a further look at these patients. They come along pretty frequently to us. There's about 140 per 100,000 in the population of the United States. And in those with a Northern European heritage, that is even increased further. There's a peak age of about 30 years old, and they're typically being treated with immunosuppression or immunomodulating medications. If this is the case, in the peri-anesthesia period, those medications should be continued, and consideration should be given toward giving stress dose steroids for the procedure that's going on. Speaking of stress, procedural otherwise, emotional stress, all these different types of things, may also markedly increase the risk for flare-up among multiple sclerosis patients. Autonomic instability is possible as well, and that makes maintaining temperature a very, very important kind of thing because it may be difficult for them to control. You don't want the temperature too warm, you don't want the temperature too cool in the room. You have to pay much more attention to that. Warm fluids are very important. But as far as the anesthetic choices themselves, it does not appear that there is really much of a difference in outcomes whether you use a general anesthetic with volatile anesthetics or with a total IV anesthetic. Regional anesthesias have all been used with no difficulties. But when using neuromuscular blockers, you do have to pay attention to what you choose there. The duration of action may be unpredictable. They seem to be safe for the non-depolarizing medications, but you may end up with a block that lasts longer than you would otherwise feel you may. The one thing that should be avoided, because again, you're going to be having this lack of neuronal input to the muscle cells, and then perhaps a potential increase in extrajunctional receptors, is succinylcholine. Succinylcholine may induce hyperkalemia in these patients. It's not as dramatic as it is in some of our other patients we'll be talking about later, but it still remains a concern. It's not unusual as well that some of the pulmonary musculature can be involved in the multiple sclerosis with these patients. And respiratory therapy is often involved. Poor cough may be present, and it may be that you end up having to have a patient who remains intubated postoperatively that you might otherwise not have expected to. Physical therapy immediately post-op is critical as well, although likely not in the realm of our work as anesthesiologists in the operating room. If you're going to be taking care of the patients in the ICU or other places, arranging post-op physical therapy is a very important component of taking care of these patients. The next disease process we'll talk about are the motor neuron diseases. Again here, looking at our American Board of Anesthesiology keywords, we'll be considering 3: amyotrophic lateral sclerosis, spinal bulbar muscular atrophy, and hereditary spastic paraplegia. Which of the ones do you believe this patient might have? Take a guess as we go through. For amyotrophic lateral sclerosis, or better known for years as Lou Gehrig's disease, what you'll see here is the contrast between normal neuromuscular process and the ALS patient's process. What you have is a degeneration of the motor neurons of the spinal cord, from the brain to the spinal cord, and from the spinal cord out to the muscles. And therefore, your voluntary muscles no longer receive commands from your brain, and they atrophy. It's, for the most part, a fatal neurodegenerative disease of both the upper and lower motor neuron diseases, and it regrettably is the most common motor neuron disease, with around 2 per 100,000 population per year. Preoperatively, they may have been on BiPAP coming into you. If you look at their pulmonary function test, you'll note that if their FVC is less than 50%, they tend to need that kind of support at night. They come in most frequently for supportive kinds of procedures, such as PEGs, trachs, lines, other types of things. The goal here is to try to do no harm, get them out of the operating room in as good a condition as they went in. So, best recommendations tend to be for rapid, short-acting anesthetics, only using low doses of non-depolarizing neuromuscular blockade if necessary. And again, because you're having a denervation of the muscles effectively, succinylcholine again may cause hyperkalemia. Regional anesthesia has been successfully used, and just be prepared, since there is this global weakness that's occurring, that postoperative vent support is very common. These folks often will eventually have their demise coming from inability to clear secretions, from pneumonia, and from that type of thing. Lou Gehrig himself died within 2 years of being diagnosed with this illness. Lou Gehrig, for those of you that don't know, famous baseball player for the New York Yankees in the 1920s and 30s. He actually set the record for playing the most baseball games continuously that was only within the last 10 years or so broken. So he was known as the Iron Horse, or a man of exceptional strength, and it was ironic that this was the disease that took him down. Spinal bulbar muscular atrophy. Again, along the same type of idea of what we just talked about, but it's slightly different. This is an X-linked recessive gene that occurs in males only. 1 in 40,000 males are affected. This is a lower motor neuron degenerative disorder, so it affects the progressively affects proximal limb and bulbar muscular atrophy. Again, similar to the other processes that we talked about, hyperkalemia is a big risk with succinylcholine. One thing that's very unique about this particular process is that you may have spontaneous laryngospasm even without anesthetic. But with this in mind, it may present an increased risk in the anesthesia period. This often comes on a little bit later in life, in the 4th decade, and despite there being an increasing disability, since the muscles that are involved in breathing and such don't seem to be typically affected to a large degree, you end up having a normal lifespan, but simply with increasing disability as time goes by. One of the hallmarks of this disease, if you're looking at them, is tongue atrophy, again, part of the bulbar process. And one of the other things that's unique about this one is it has to do with androgen receptor being mutant. So there seems to be possibly some kind of component of this that's similar in some ways to androgen sensitivity syndrome. But we're talking today specifically about the neuromuscular component of this. And again, this is the kind of thing you may see symptomatically as a atrophied and weak appearing tongue as one of the presenting initial symptoms. What those of you who take care of pediatric patients may see are some patients who come in with hereditary spastic paraplegia. This is a little bit more common than some of the other diseases that we're going to talk about. This has an inherited rate of about 1 to 10 to 1 in 100,000, depending on sort of where in the world you're looking and which articles you're reading. This tends to be the degeneration of the ends of cortical spinal tracts within the spinal cord. And here, the ends of the longest fibers are affected greater than those of the upper body. So as you noted on that last photo where we had the child that was there, he had on the Canadian crutches because his upper body was relatively spared and he still needed help to walk, but he was able to use his upper body strength to help him get along. The early symptoms may be mild gait disturbances and some stiffness. Later on, it's not infrequent that you'll need a walker, canes, or a wheelchair. Complicated forms may be accompanied by other kinds of symptoms, can even have cognitive impairment and the such to go along with this hereditary spastic paraplegia. All types of anesthetic have been used, and again though, since you are having a relative denervation of here, the lower extremities in particular, succinylcholine should again be avoided so to avoid the risk for hyperkalemia. Guillain-Barré, interesting kind of thing here. It doesn't seem to be genetically related, but it seems to be instead related to a recent illness. If you look here, in some ways similar to what we saw with our ALS or Lou Gehrig's disease, what you have is an acute polyneuropathy where the myelin is damaged. In this situation, you end up having a paralysis that's pretty diverse, but it is a ascending paralysis. So oftentimes you start with initially prickly, tingly sensation in your arms and legs, paresthesias, eventually muscle weakness that goes in the legs, and you may end up even having paralysis that would include your muscles of respiration. So this is an autoimmune response, these things are, that occur typically after a gastrointestinal or respiratory tract infection. Severely debilitating, and again, it's not terribly uncommon at 1 to 3 per 100,000 per year. Treatment for this tends to be plasmapheresis or IV immunoglobulin. Very common to need respiratory support. 25% of the patients will need respiratory support, and as many as 10% will die from associated complications that arise from Guillain-Barré. It also can be very debilitating, as 10% suffer long-term sequelae and physical dependence because they never fully recover from the effects of this syndrome. Once more, really the avoidance of succinylcholine is the primary point that you'll see for these patients, because they are effectively a denervated muscle patient, allowing the extrajunctional receptors to come into being, which then makes there to be a much more likelihood for a large potassium efflux, hyperkalemia, and a resultant possible hyperkalemic arrest. Charcot-Marie tooth. The last of this group of disorders that we'll be talking about. Again, very interesting. It's a length-dependent degeneration of motor and sensory nerves. It doesn't seem to be related to a recent illness or any of the such, but instead it's a heterogeneous disorder mutation of a myelin gene. So the myelin itself is affected. It also tends to be length-dependent ones. So you'll see the hands and the feet get affected more than other parts of the body will. And they even have a name for the legs, because the legs get demyelinated distally, and they'll call them stork legs because the calves can be so skinny. And they also have claw hands because the hands will be affected to a significant degree. All types of anesthetic have been given. Neuromuscular blocking drugs, the non-depolarizing type, have been used with a sensitivity noted to be increased, and succinylcholine, again, may cause hyperkalemia. And these are the symptoms that I just was talking about. Moving into the primary muscle diseases, you've got muscular dystrophies and mitochondrial myopathies. The muscular dystrophies are caused by a dysfunction, if you will, in dystrophin that ends up having an impact in making the myocyte fragile. Broadly, they can be divided in the most common types are Duchenne's, Becker's, limb-girdle, congenital, and myotonic. The ones that we hear and think about most often tend to be the Duchenne's and the Becker's. The Duchenne's patients typically start to have, again, these are X-linked, so they are seen in males. They tend to present initially between 2 and 5 years old, the Duchenne's, and they will tend to start to have weakness that comes on. They even sometimes have to try to sort of crawl themselves to their feet by using their own bodies and legs and things as extra help to get up. So if you see them trying to get up, they usually struggle to get up, and that's one of the early symptoms of Duchenne's. By the age of 10 or 12, they're typically wheelchair bound, and by the age of 18, they typically have passed away. They have the breakdown of the sarcolemma resulting in myofibril atrophy, necrosis, and fibrosis, with progressive muscle weakness and cardiomyopathy. They almost uniformly have cardiomyopathy as they get to be older. The Becker's is a little bit less. They don't have a total loss of dystrophin, but a functional limited dystrophin protein. And the symptoms may be more mild. But one thing that's interesting about those patients are oftentimes their cardiac dysfunction is out of proportion to what their other dysfunction is. So it's important to make sure that you know these things when you're doing this, and absolutely get an echocardiogram if you have any question about their cardiac disease process. These patients absolutely contraindicated for succinylcholine. That seems to be the one medication that causes an increased amount of risk. As far as volatile anesthetics, they do not seem to be a problem here necessarily. There is some subtle indications that rhabdo may be slightly increased with volatile anesthetics, but it doesn't seem enough to have a definitive statement about safety. The bigger risks tend to be respiratory compromise, and again, the cardiac risk that is increased to almost universal dysfunction as age goes by. Limb girdle is a proximal muscle weakness that is from a variety of different disorders. There's a variety of different, more than 18 or so different genes that can be affected, and each of them has their own special things that are going on, but broadly they can be categorized as patients who have proximal muscle girdle weakness. And in these patients, they have a similar approach to the Duchenne's and the Becker's muscular dystrophies. And then we've got our congenital dystrophies. And these are the ones that are pretty obvious almost right from birth. When you have one of these patients and you see them just after they've been delivered, they'll be floppy. They most likely will be slow to meet milestones. Their initial APGAR scores are often low, and they may not meet some milestones at all. It's one of the rare forms, thankfully, and they almost uniformly, again, have significant cardiomyopathies and a relatively short lifespan. The contraindications and the concerns that we talked about for our other dystrophies are the same for this particular one. Myotonic dystrophy is the most common form of all, with 1 in 8,000 patients, and affects both men and women. This is a generalized weakness that's both seen in the face and then also in the extremities. But the interesting part about this is that it actually has a myotonic component. Myotonia being that stiffness rather than a paralysis or a weakness. It's a stiffness that occurs here. Another thing that's interesting in this patients are, in contrast to specifically having the issue with the cardiomyopathy, these patients have a mitral valve prolapse 20% of the time. Myotonic contractions, though, can be stimulated by anesthetics. It's been seen with almost all the ones we use for induction, propofol, etomidate, ketamine, etc. Hypothermia can cause it, electrical stimulation or mechanical stimulation can cause it as well. And the treatment for those myotonic contractions that you'll have readily available to you in the operating room tend to be phenytoin. Succinylcholine, again, is something to be avoided here, as it can cause prolonged fasciculations in these patients. Mitochondrial myopathies. These are a set of myopathies that occur because of a defect in the respiratory cycle of mitochondrial metabolism. They're, again, not that uncommon, 1 in 4,000 patients. They have proximal muscle weakness, increased lactic acid production. They have a positive muscle biopsy if you look at them, so that's one way to make a diagnosis. And there is a theoretical risk, and you'll see this when patients come in to see you. They will often say, I cannot have propofol or thiopental or the such if we have thiopental available, because it has this risk of making things worse, and I cannot take that medication. It doesn't seem to be the case, though. In reality, all the anesthetics that we use have been used safely, and you have the opportunity to be able to take care of your patient in a fashion that you would normally take care of any patient, if you will. You need to just do a couple things. It's avoid shivering, hypoxia, fat, and those kinds of things, anything that might increase lactic acidosis. And again, same as in the rest of these patients that we're talking about, succinylcholine should be avoided for the risk of having a fatal hyperkalemic event. The channelopathies are what we'll talk about in this next portion of the slide. Again, it can be chloride channels, it can be calcium channels, sodium channels. What we're going to talk about next will be those type of channels that you see here. We're also going to function primarily on the channelopathies that go along with the neuromuscular type. So we're not really going to look at the cardiovascular system, respiratory system, endocrine, those type of things. Cystic fibrosis, for example, is a channelopathy that affects the lungs, it affects the endocrine system, but this is not within the purview of this lecture. We're going to talk about the ones specifically affecting neuromuscular function and disorders. The first genetically characterized of the channelopathies were the primary skeletal muscle disorder ones, and they range from a myotonia to a flaccid paralysis. We're going to hit on the myasthenic syndromes first. Of course, the one most people recognize right off the bat is myasthenia gravis. Then you've also gotten Lambert-Eaton myasthenic syndrome, and then a congenital myasthenic syndrome. So myasthenia gravis is a disorder where within the axon, where it comes down and connects, or doesn't connect, but comes in close proximity to the muscle, in this area where your acetylcholine is going to be released by exocytosis from the axon and diffuse across the acetylcholine receptors, they're going to now have to compete with acetylcholine receptor antibodies. So the weakness of myasthenia gravis comes because you've got a competitive inhibition, if you will, of the effects of acetylcholine as it's discharged from the neuron, from the axon, into the muscular space. So therefore, you will not be able to have the same effect from the same quanta of acetylcholine that's discharged from the neuron, and therefore you get your weakness. It's the prototype of the autoimmune channelopathies, and it seems to be directed primarily against the postsynaptic acetylcholine receptors. It directly blocks this receptor, and there is an inhibition based on this competition. Post-op ventilation is likely with the higher the dose of the anticholinesterase the patient's been receiving preoperatively, correlating with an increased likelihood of post-op ventilation. These patients don't have a contraindication to using succinylcholine, but again, if succinylcholine is going to be given, it's going to also be competing with these antibodies for its effect. So the dosing you give will likely have to be higher, but then the time it's going to be working will also be prolonged as well. So its duration of action will be longer. If you use non-depolarizing medications, conversely, you actually use a lower dose of those to affect the same thing. Because remember, in order for there to be a neuromuscular transmission and a skeletal muscle contraction, the acetylcholine has to bind to two components of the receptor. There's two binding sites. This actually just makes it simpler for the neuromuscular blocking agents to block that, as some of them are blocked already by antibodies. Typically, since they're already weak to begin with, volatile anesthetics are frequently sufficient for adequate muscle relaxation for these patients. Lambert-Eaton, it's immune-mediated channelopathy, similar in some ways to myasthenia gravis, but it's more often a part of a perineoplastic syndrome, specifically small cell lung cancer. This particular one is similar to the last one, but slightly different. What's happening here is that you've got this autoimmune antibody that's actually hitting the calcium channel receptor instead this time. The calcium channel then does not open, there's not a calcium influx, and there's not a then subsequent release of vesicles from the nerve terminal. Therefore, the transmission of the nerve impulse does not make it to the muscle. The congenital myasthenic syndromes are a heterogeneous group of genetic disorders that occur in all different orders. They come from presynaptic, postsynaptic, synaptic, but the ones that are most likely seen are postsynaptic and will fit similar to the ones we had before. The majority are caused by mutations in the muscle nicotinic acetylcholine receptor, and what will happen is that the activation of these muscles will result in acetylcholine release from the motor nerve terminals, depolarizing the cytosolic release of calcium from the SR, and which is all required for muscle contraction. That won't occur because these receptors are defective. So again, this is again a receptor issue that's caused by a defect in the acetylcholine receptor that oftentimes may preclude sodium from coming into the cell. The depolarization doesn't occur and the such. Biggest symptoms of these patients are weakness and fatigability after exercise. Some ion channel myotonias will be what we talk about next. They include acquired neuromyotonia, myotonia congenita, hyperkalemic periodic paralysis, paramyotonia congenita, potassium aggregate myotonia. And these are all three lumped together, not on my part, but by the ABA. That's how come these are all three put together in that category. And then number 4, the hypokalemic periodic paralysis. The acquired myotonias are an inflammatory disorder. They also are autoimmune, and these ones affect the voltage-gated potassium channels. So again, we see these recurring things attacking the sodium channels, autoimmune attacking the acetylcholine receptors, autoimmune attacking the calcium channels, and now here we have an autoimmune that's attacking the voltage-gated potassium channels. So in these, you've got an abnormal nerve impulse from the peripheral nerves that results in continuous muscle fiber activity, because what you don't have then is the potassium efflux that causes the repolarization of the cells. So what you end up having is this progressive muscle stiffness and cramping, especially hands and feet, and delayed muscle relaxation. The symptoms may happen under sleep. They may happen even under general anesthesia. So the stiffness may be there throughout the entire process. And 20% of these patients may have a thymoma. So the first time you may be taking care of them may be in order to have this thymoma excised. So just look at the clinical spectrum of the channelopathies that we looked at. Some have muscle hyperexcitability, like we just are talking about now. And then some, as you'll see, will have muscle hypoexcitability. This, again, is another one of the myotonias that has extreme muscle stiffness, myotonia congenita. This is a loss of function mutation in the CLCN1 gene that is one of the skeletal muscle chloride channels. These patients, interestingly, may actually look athletic, if you will. They may be sort of muscly looking. They have this extreme muscle stiffness and delayed relaxation, which effectively almost as if the muscle is getting a workout at times. They, though, eventually will end up having weakness because these muscles end up becoming damaged and fatigued as time goes by. In these particular patients, since they already are predisposed toward extreme muscle stiffness, severe masseter spasm may occur when you give succinylcholine, such that you cannot get the mouth open even to put the breathing tube in place. So intubation may be exceptionally difficult in these patients with this myotonia congenita. It does not appear to have any increased likelihood, though, of MH. It's not on the same gene. The gene on MH is on chromosome 19, not the same at all. But dantrolene may work to help to decrease the stiffness. These patients, you have to maintain nomothermia because the precipitation of myotonia may occur with hypothermia and shivering. Hyperkalemic periodic paralysis is an interesting kind of thing. These patients have an autosomal dominant mutation of the voltage-gated sodium channel. It's a pathologic increased sodium current, and this has an increased tendency of membrane depolarization and a prolongation of depolarization. And what happens then is that you have an efflux of potassium that occurs because of this and hyperkalemia. So the resulting effect of this is the hyperkalemia that's occurring. It's not that the hyperkalemia necessarily is causing it, although stress or high potassium meals seem to possibly provoke an attack. This is a flaccid weakness with elevated potassium, and it's relatively short-lived at 15 to 60 minutes. Potassium cholinesterase inhibitors and neuromuscular blockade with depolarizing agents may aggravate the myotonia. And the other thing to note is that you may have prolonged muscle weakness with succinylcholine. These patients, you'll also see masseter spasm, skeletal muscle stiffness may occur, and it appears that all types of general, except using succinylcholine, are okay because of the risk for having hyperkalemia, increased potassium, which would cause worsening of this. Any agents that may increase potassium should be avoided, such as metoprolol or the kind of beta agonist. Conversely, things that will decrease potassium extracellularly may make this better. So glucose, insulin, epinephrine, calcium, glucagon, all these things may abort an attack. Again, no increased risk of MH in these patients. You can avoid potassium-containing solutions, and again, avoid succinylcholine. The last several of these we're going to consider are coming up here. Paramyotonia congenita and potassium-aggravated myotonia we'll talk about now. With paramyotonia, it's an autosomal dominant voltage-gated sodium channel dysfunction. And this one comes on early in life. This is interesting because it's cold-induced flaccid paralysis. There's even been evidence of individuals who, after eating ice cream or drinking a cold beverage, may end up having facial paralysis after they've had such a meal. Don't give these patients succinylcholine. Don't use anticholinesterases for them, and keep them warm. Otherwise, general anesthesia, regional anesthesia are both okay, and there is no increased risk of malignant hyperthermia in these patients. For the potassium-aggravated myotonia, this is an autosomal dominant problem that begins in childhood or adolescence. It's rare, only reported in a few individuals and families worldwide, but it is something that is included in the keywords from the American Board of Anesthesiology's list that we have. It's a sodium channelopathy, and it seems to be dramatically affected by potassium ingestion. So again, here, avoid all potassium-containing solutions, and don't give any potassium for the potential risk of even a mild increase in potassium that would come with succinylcholine may precipitate this. Our last topic is hypokalemic periodic paralysis. This is the one that, if you're going to see one of these different types of things, you may see. This is the most common form of periodic paralysis. This one is triggered by a variety of different things, including rigorous exercise, stress, pregnancy, high-carb diet, hyperthermia, and even insulin. It's an autosomal dominant mutation, so that means that it's going to be passed along easily. And it involves a mutation in the skeletal muscle voltage-gated calcium channel gene, or the sodium channel gene. There is no myotonia in this, and the consideration about this particular problem is that the duration of the paralytic attack acts longer, significantly longer, than the hyperkalemic periodic paralysis. It could be hours, it could be days that you end up having paralysis. Thank goodness, or thankfully, respiratory and cardiac muscles are generally unaffected. So even though you're paralyzed, you can still breathe and your heart still functions appropriately. The different types of things that you would like to avoid during the anesthetic for these patients is post-op stress, glucose-containing you do want glucose-containing IV solutions, and long-acting neuromuscular blockade has been associated with post-op paralysis. So the overriding theme in most of these cases is if there's any choice and any desire to do neuromuscular blockade in closing, you're almost always best off if you can avoid succinylcholine. The vast majority of these particular disease processes of patients who have neuromuscular disease have a concern with using neuromuscular blockade. Any time that you're going to have a denervated muscle, you're going to have extrajugular receptors increasing, and the increased risk for a massive efflux of potassium with the use of succinylcholine. So in any circumstance when you believe those conditions may be met, avoid succinylcholine. Other than that, there are very few limitations on what anesthetics you can use and give. You just have to be judicious, make good choices, and adjust your medications up or down appropriately. In closing, you may have recognized that fellow in the first slide early on as Professor Stephen Hawking. Probably now currently the most famous survivor of ALS. He's been confined to a wheelchair for quite some time, but still very productive, very active. And these are his words, despite the fact that he has such debilitating illness. Remember to look up at the stars and not down at your feet. Try to make sense of what you see and wonder about what makes the universe exist. Be curious, and however difficult life may seem, there is always something you can do and succeed at it. It matters that you just don't give up. Keep these words in mind as you move forward in your career, and particularly as you prepare for your examination.